Good morning, everyone. Welcome to the Provider Roundtable, DBHDS. Today, September 25th, 2024. We have a few announcements before we get started. I hope you all can hear me. If you have a question today, we ask that you use the Q&A to write your questions. We'll be entertaining all questions at the end of all presentations today. We also have a few announcements that we will send out to you with the Q&A for your information. So today we have information from Heather Norton, our commissioner. She was not able to join us. She's asked that we let you know as an audience that DBHDS continue to negotiate a permanent injunction with the court. A revised permanent injunction is due to the court tomorrow, and the next meeting with the judge is scheduled for October 3rd, 2024. I'd also like to share regarding QMR that there is new language in Chapter 2 of the DD Waiver Manual, and it states that providers must permit Community Services Board support coordinators and case managers access to the premises at any time to see the individuals in service settings and allow full access to the individual's records on site. Providers may not deny access to records or refuse entry to the premises. So with that, we'll move along to the next slide, please. So Ms. Tanika Goldman, if you're here.
Good morning. I am here. Can you hear me?
Yes, welcome. Thank you
Oh,
for making
perfect.
time.
No, thank you. Thank you for fitting me in. So just a few quick updates from the Office of Human Rights. Here on this first slide is a reminder about our human rights committees. Particularly on this slide is some contact information for two committees that are in dire need of members. As you know, the LHRCs conduct due process reviews, like reviewing restrictions that last longer than 7 days after that threshold has been met, or behavioral treatment plans with restraint and timeout prior to implementation. When we don't have enough volunteers for a full committee, these types of reviews, or more importantly, ensuring the right of individuals receiving services to be free from unnecessary restraint and restriction, is significantly diminished. So if you or a colleague or individuals that you support and or their family members have an interest in volunteering on a committee, please access all the information on our website. Next slide. A note about trained investigators. So we know that when a provider receives a complaint involving abuse, neglect, or exploitation, the person conducting that investigation must be trained. Our office has noticed from our community look behind that more and more providers are submitting the risk management attestation form as evidence of investigator training. So I believe there's an updated form with a newer link that points directly to our website and the training calendar, but I wanted to make sure everyone is aware that this form in and of itself is not evidence of training. Evidence of training is a certificate of completion from a legitimate investigation training program or organization. This includes the investigator training offered by our office, but also includes any other training that a provider has verified as appropriate. Also, reviewing the training video on our website and developing your own certificate does not meet the requirement of being a trained investigator, because there's no real way to confirm that the video has been viewed in its entirety. So the video is a supplemental resource only, and we do encourage providers to use it. So for example, after an employee has been trained fully, they've received that training, they can use this video as a refresher, or as an interim solution when a provider staff has registered for a training session, but that session is more than 30 days away. Next slide. Just excited to let you know that we have added 2 more abuse neglect investigation training sessions. One's actually happening tomorrow, and the next one is happening Thursday, December 19th, and that's based fully on feedback. So I hope you'll take advantage of that. The next slide is just letting you know that in July of this year, our office revised what we call our compliance verification checklists, both for new providers seeking to be licensed and for existing providers who are trying to modify a license or add another license type. So these forms are on our website, but most important to note for this group is that after providers have submitted a services modification to the Office of Licensing, you must also email this completed form to the Office of Human Rights using the link you see there, ohrpolicy@dbhds.virginia.gov. These forms are important for our office. They help us ensure that providers have appropriate human rights policies and that we stay connected to each other should a provider add a new address or change an administrative location. The next slide I'd just like to include as a reminder of your points of contact for our office. That's going to be based on the location of your program. This map, along with actual emails and phone contacts, is on our website for all of our advocates. And then the last slide just shares all the ways that you can stay connected. And that website I keep mentioning, right now on our website is a new opportunity for public comment on proposed draft, non-controversial, streamlining, clarifying, and regulatory reduction amendments to the human rights regulations. So a link to the public comment forum, which is open now and closes October 21st, along with a PDF of that draft, is also on our website. All licensed providers should have received a constant contact message about this on Monday. And if you did not, you can use the link at the top of this slide to make sure you register to receive communications directly from our office. That was a lot, but that's it. Thank you so much for your time.
Thank you, Tanika. And before Heather Hines present, I'd like you to know that we are not able to use our chat today. Please put your questions in the Q&A, and we are holding all questions until the end of all presentations. Heather, if you're here, it's your opportunity to share.
Thank you.
Heather Hines.
Thanks so
Morning,
much.
welcome.
Good morning. You can go to the next slide. So the Individual and Family Support Program, just briefly, for those of you who are not familiar, we help people with DD who are on the DD waiver waitlist and their families. Some of our programs and resources are also available to people who need support but aren't on the waiting list yet. So we do some outreach for those folks, and also people already enrolled in DD waiver. And this slide shows the 4 main components of the program. The funding program I will talk more about in just a moment. And additionally, we partner with organizations like the Center for Family Involvement and the ARC of Virginia for family and peer mentoring programs, as well as leadership for empowerment and abuse prevention training. The My Life, My Community website, developed with Virginia Navigator, is our resource hub. And we also have a call center where people can reach out for more help. And the community coordination program involves regional and state councils made up of people with DD, their family members, caregivers, and professionals. Regional council members help to organize coordinated council events to provide information to people on different topics throughout the year. They build local support networks, act as liaisons with the IFSP, and share helpful information in their communities. And the State Council provides general recommendations to the department on its plan to increase family supports throughout the Commonwealth. Our marketing and messaging efforts ensure vital information reaches individuals, families, and the wider community. Next slide. So it is funding season for the IFSP, and wanted to let you all know what's happening this year. First of all, applicants for the funding must be on the DD waivers waitlist and also be living in their own home or a family home. And the application can be submitted by either the individual themselves who's on the waitlist or by their custodial family member. And the funds are allocated by the General Assembly up to $2.5 million. Half of those funds go to priority 1 and half go to priority 2 and 3. There's a maximum of $1,000 that priority 1 applicants can apply for, and then a maximum of $500 for priorities 2 and 3. And the categories that include the needed items and services are safe living, community integration, and improved health outcomes. And this happens annually in the fall typically. This year, eligible applicants can apply between October 15th, so it's coming up pretty soon, and November 13th. That is a 30-day window for people to apply anytime during that time. There's no rush. It's no longer first come, first serve. Hasn't been for a couple of years now. So we're still trying to get the word out to people. They can take their time and apply anytime during that 30-day window. And there's the link to where to apply. It's actually on the waitlist portal. It's also the IFSP funding portal. And then we have a website or a page on the My Life, My Community website with all of the resources and information people need about funding. And we're uploading information this week and next week so that everything will be there when people are getting ready for funding. We have quick guides and user guides and tip sheets and the guidelines and a video. We have trainings coming up the first 2 weeks of October. So there's lots of information to help people with that. Next slide. So some things that support coordinators need to know as they're assisting people on the wait list, that they can call that helpline with the number there, and the operators there are trained. They know all about how to apply, and if they can't solve the problem, we work with them closely to resolve any issues that applicants have. And again, the application link is there. And one main thing we ask is that people, in order to log into that portal to apply, their information needs to be accurate and WAMs. And that means the last 6 of their social security number, their date of birth, and their last name. And again, it's the individual on the wait list information that they're using to log in. Even if it's a family member that is applying for them, they have to have that information accurate. If anything's off, they won't be able to log in. So they can go in and try logging in now or in the next few weeks prior to when the application open period is, and check it out and make sure it works. That way they're not stressed when they try to log in and it doesn't work. So yeah, that's just a little tip for support coordinators to just check your waitlist folks to make sure that their information is accurate and WAMs. Next slide. So just a couple new things this year. The application is pretty much the same. We just tried to enhance a few things to make it even more user friendly. But we did make some changes to the guidelines with input from previous applicants, from our councils, and it was on town hall for comment. It just closed. One of the main changes was that we will now allow for priority 1 applicants who did not receive funding in that first half. If they don't have a high enough CNS score, then they would be placed in the funding pool with priority 2 and 3 applicants to ensure that they have a chance at receiving an award. What was happening is 2 years in a row, the people with the lowest CNS score on priority 1 really didn't have a chance. And so we changed the guidelines to allow for that to be more fair for them. And the other thing is that we cannot issue funding to individuals if they are no longer on the wait list at the time of funding issuance. So if someone is, if we find that they would be approved for funding, but then they're removed from the wait list or they're enrolled in waiver between the time they apply and the time we issue funds, they won't receive funding. And so we'll have information about that and how that will work on our funding page. And there's like I said, all that information is on the funding page. Next slide. So here's just a little information about our previous year. We had 4,872 applicants. We approved 3,765 applicants and had to deny 1,107. And then one good thing that we're really proud of is that between the FY23 and FY24 funding cycles, we had a 50% reduction in requests for assistance. So We're hoping that means that people are having an easier time accessing and completing the application. So we're really proud of the work we've done, and our partners work with us to make that an easier process for everyone. Next slide. And this just shows you that the awards were equally divided pretty much between priorities 1, 2, and 3. And then the funding categories that people applied for, again, were also equally distributed between the 3 categories, with safe living environment being the highest. Next slide. And we wanted to make sure you all knew, this went out on the provider listserv as well, our IFSP First Steps Guide. It is a really helpful document. We want that to go to everyone who is interested in DD services on day one, because it really provides a lot of helpful information when people are getting started about resources, about IFSP, about the My Life, My Community website, funding, and it includes information about crisis services. So just encouraging you all to look for that in your email. It went out on September 11th. So take a look at that and please share that with everyone that you're working with, so that they have all the information that they need to navigate the system. Next slide. We have an event happening tomorrow, just a last minute plug. If you're able to attend, if you're in the area, it's in Weir's Cave near Harrisonburg. It's about assistive technology. We are really excited about it. We have about 15 organizations coming and sharing information and AT devices and tools. So we know it's last minute, but we'd still welcome anyone who wants to come. And information is on My Life, My Community as well, and the link there. Next slide. And I think I'm about out of time, but just the last thing is I'd like to encourage you to share this with people who might be interested in being part of our state or regional council. We are extending our application past this Friday because we really need people with developmental disabilities, self-advocates. And so we are just asking people to check in and share this so that they can we can get some more representation from people with DD. We have plenty of families, but we need more people with DD. Next slide. And that's it. That's just how you can stay in touch. Thanks so much.
Thank you, Heather. And before we start with our next presentation, I have worked, and I think the chat is now accessible. So if you have questions, please put them in the chat. Apparently the Q&A is not yet operational. We do apologize for that. Please put your questions in chat. We will engage and answer questions at the end of all presentations. Thank you very much. And now our next presenter is with the Emergency Preparedness, Office of Licensing and Office of Integrated Health, Angelica Howard and Christina McCrae.
Thank
Good
you,
morning,
Sophia.
ladies. Welcome.
Good morning. Thank you. So hello and welcome to our presentation on emergency preparedness and crisis emergency interventions. We are so excited we were given the invitation to present this valuable information, and we hope you also find it helpful as you support individuals in our system. Originally, this presentation was presented in the July OIH Regional Nurses meetings, and today we'll present just a portion of this training, and we hope this will spark you to seek out the full PowerPoint on the OIH website when it's posted. My name is Angelica Howard, and I am the Associate Director of Administrative and Specialized Units within the Office of Licensing, and I will let my co-presenter introduce herself, and we'll begin this presentation.
Good morning, everyone, and thank you, Angelica. Thank you all for having us. My name is Christina McCrae, and as you can see on the screen, I am the SIU manager, and we'll go ahead and jump right into things. So, as Angelica mentioned, this is a condensed version of our of our presentation. Today, we're only going to briefly cover Reg 530, which is, of course, your Emergency Preparedness and Response Plan. And we'll take a little bit of a deeper dive into the written policies and procedures for crisis and emergency interventions, some of those required elements. We're going to talk a little bit about the 911 scenarios and how they can be utilized in medical emergency scenarios. And then, of course, we'll go over some frequently asked questions. We can go ahead to the next slide. So, as I mentioned, we're not going to go completely through Reg 530A. Most of you know that this is a lengthy regulation. But really, this regulation requires that providers have a written emergency preparedness plan. This plan should be for all services and all locations. And really, what we wanted to drive home is that you're going to be preparing for any event that you can think of that might disrupt the normal course of your service delivery. And so, a lot of times when we think about emergencies, we're thinking about fires, natural disasters, tornadoes, hurricanes, flooding, etc. And other scenarios where you might need to shelter in place or evacuate. I think in more recent years, most of us are familiar with, now we're incorporating bomb threats, terrorist attacks, active shooters. These things are very real. And so what, again, we want to drive home as part of this presentation is that medical emergencies should also be considered as a part of your emergency preparedness plan, because they are events that can disrupt your service delivery. And you want to make sure that you are creating a plan that helps you or aids you in handling those emergencies. So we're thinking about individuals or finding an individual seriously injured, choking, unresponsive, or any other acute medical incident. And so what this reg really drives home is that you should always be planning for emergencies based on your services and needs of the individuals specific to your organization, documenting those procedures, evaluating the effectiveness, and updating your plan as time goes on. Next slide, please.
Okay, so now we're going to review our crisis or emergency interventions regulation 700, which states that the provider shall implement written policies and procedures for prompt intervention in the event of a crisis or behavioral, medical, or psychiatric emergency that may occur during screening and referral, at admission, or during the period of service provision. So again, I want to point out that this regulation also includes medical emergencies. So implementing a medical emergency drills at your agency is most advantageous to help prepare staff for real medical emergencies. Next slide. So furthermore, B states the policies and procedures shall include a definition of what constitutes a crisis or behavioral, medical, or psychiatric emergency. Number 2, procedures for immediately accessing appropriate internal and external resources. Number 3, employee or contractor responsibilities. And number 4, the location of the emergency medical information for each individual receiving services. Number 3 is bolded, as this is one of the most frequent areas that are cited during our DD-SIU death investigations that involve staff intervening during a medical crisis. It's often discovered that employees are either not fully aware and or not fully trained in their responsibilities during an emergency. Next slide. It's important that providers' policies and procedures include clear instructions regarding their employee responsibilities during a crisis or a medical emergency. Some things providers should consider when developing their policies and procedures are: number 1, are there sufficient staff to safely evacuate during an emergency based on the needs of the individual? Often providers forget to include sufficient staffing in the event of an emergency, and it's important to evaluate the needs of the individuals to determine appropriate staffing levels and include sufficient staffing in the event of an emergency. Number 2, does the policy clearly outline each employee's responsibilities? Number 3, does the policy indicate that in the event of a medical emergency, the first priority is to call 911, and then once the emergency has been addressed, then contact a manager or supervisor? We must empower our frontline DSPs to take immediate action in the event of an emergency. Time, of course, is essential in the event of an emergency. Number 4, does the policy specify that in the event of a medical emergency where loss of consciousness is involved, that staff are to render CPR until EMS arrives and takes over. Number 5, are the individual's medical emergency forms updated routinely and whenever there is a change in status and easily accessible to all staff in the event of emergency? Those medical emergency forms are essential to have and use in the event of emergency that involves calling 911. They provide essential information to first responders, such as their current diagnosis, their current medication, their age, etc. Number 6, does the policy specify how staff should document the crisis or emergency after the event? So documentation of the crisis or emergency event is required. Remember, per regulations, providers have 24 hours from discovery of the reportable incident to report in our CRIS system. Providers should also complete a root cause analysis if applicable. For emergencies involving implementing CPR and contacting 911, remember, as a provider, you have 30 days from discovery to complete your root cause analysis. We highly encourage providers to attempt to secure copies of the 911 audios through the FOIA process to help confirm that staff intervened appropriately. Often during our investigations, employees will share with their supervisors that they took appropriate action, but it's not until we get that 911 audio that a provider can be absolute certain that employees took appropriate action during the emergency. Next slide. Okay, we got a question. I know people can't come off mute, but those that can, if you answer or put it in the chat. True or false, all 911 centers are trained to give CPR instructions over the phone. Okay, I see a true. Anybody else? I see another true. I see a false. See another true. Okay, we won't spend too much time on it. I'm seeing more trues than false. So go ahead and click the button here and let's see what the answer. It is false. It is false. Next slide, please. So it shall be noted that not all 911 centers are trained in emergency medical dispatch, which includes providing detailed instructions via the phone for the following items: CPR, seizures, traumatic injuries, heart attacks, and other major medical emergencies. You can call your local non-emergency number for your locality of your service to ask if they are emergency medical dispatch trained. However, it does not change the fact that all staff should be prepared to initiate emergency medical responses when needed. We are going to be reviewing and covering some scenarios, and we hope that you will utilize the scenarios as a tool to establish emergency medical response trainings within your agency. Next slide.
All right, thank you, Angelica. And so as Angelica said, we're going to talk about some 911 scenarios. What we want you to know is that the upcoming slides were developed as a tool to assist DBHDS licensed providers with having a better understanding of what to expect when 911 is utilized for these medical emergencies. The tool was developed by former EMS emergency professionals, former law enforcement professionals, and members of the DBHDS Office of Integrated Health. This is not an exhaustive list of 911 scenarios, but the first two scenarios that we're going to go through serve as a template for what you might expect when you have an individual who is non-responsive or not breathing and dispatch is trained in emergency medical dispatch. Now, the last scenario gives us an example of what to expect if your 911 locality is not emergency medical dispatch trained. And again, it's important to remember to stay as calm as possible, speak clearly when contacting 911, answer all the questions, remain on the line until EMS officials arrive and/or until the dispatcher indicates that it's okay to disconnect. Next slide, please. All right, so this scenario, individual is non-responsive. And so this is typical of what you might hear. The dispatcher, where is your emergency? Provider, you should be able to provide your full address and phone number. If it's a group home, please tell them this and that you are a caregiver. You would be surprised how often staff struggle with this part of the phone call. Dispatcher, what is your emergency? You should be able to describe exactly what you see, as the individual will not answer or respond like they normally do. They're not breathing. They feel warm, cold, bleeding, visible injury. An example of this, 54-year-old male, unresponsive after a seizure. Dispatcher, may I have your name? Please confirm your address. Again, we got to drill home these addresses. Provider, please answer accordingly. This allows for minimal miscommunication due to dispatchers often doing more than just answering the 911 calls. During that time, they're also dispatching fire, EMS, police across your jurisdiction. At times, these centers get loud with crisis incidents. Although your emergency is important, there are times where there are major incidents or mass incidents they are also working on. So you want to have staff be as clear and concise as possible. How old are they? By this time, the expectation is that the staff have the binder, a record for the individual, have that face sheet handy, and they're able to give that or readily give that information. So example, again, it's 54-year-old male. Next slide, please. Okay, and so this individual, again, still non-responsive. Dispatch, are they conscious? Provider, the staff should be thinking, are they awake? Are they alert? Are they responding as per the norm when you call their name? If you place a hand on them, do they make eye contact or verbally respond? We want to look for answers such as they are breathing, but they're not answering me. You really just want to drive home with staff that what it means when they're asked, is the individual conscious? Because staff, again, struggle with that question. Has anyone at the location tested positive for COVID? Yes, this is still a question that can be asked. You want to make sure that you're being truthful. It's not going to hinder you getting help. Dispatcher, is the person turning blue? Are they experiencing chest pain? Are they breathing now? Do you hear any noises? Provider, remember that this is where the dispatch is attempting to see how they can best help you. And so the answers to these questions are very important, and we want to make sure we're training staff to look for those things. What were they doing when it started? Provider, were they outside? Were they eating? Did they just take their medications? What were kind of those immediate things that were happening directly before the incident? And so again, you want to work with staff on being able to describe, yes, they were eating and had a seizure, or I went to give them medications and they were lethargic. They just didn't seem right. You want to be able to provide some of those details, and hopefully through practicing, we can get there. Next slide, please. Okay, so scenario one, individual non-responsive. Again, we're still going. How long did it start? When did you last see them awake, alert, acting normally? Are they diagnosed with anything? Use your face sheet. Staff do not need to be guessing and eyeing at this point. They should have that information right in front of them because, again, we want to optimize the help that these individuals are going to get. Do they take any medications? Most of these individuals take plenty of medications that you're not going to be able to just list off by memory. And so again, this is where you want to have those face sheets there and available for staff to use to share the information. Next slide. Okay, second scenario. Now we have an individual who's not breathing. Some of these things are going to be very similar that you might expect. Again, dispatch wants to know where's the emergency. You want to be able to, again, give the address. I cannot stress it enough. Staff struggle with knowing the address of the location that they are at very often. What is your emergency? You must be able to describe exactly what you see, as the individual will not answer or respond like they normally do. They're not breathing. They feel warm. You want to have some of these phrases that staff can kind of recall. This is what I'm looking for. This is what I'm assessing for. Dispatcher, may I have your name? Confirm your address again. Again, we just went over this, but it's important because this communication needs to be clear and as concise as possible and hopefully not take 2 minutes, which sometimes it does, for staff to recollect just where they are. Next slide, please. Again, so remember, this individual is not breathing. Does anyone there know CPR? The dispatcher will ask. And if you've been trained, you're going to indicate yes. And we want staff to remember that even if you're stressed, you can say yes. And this time you can let them know that you want assistance. It is okay to want assistance. We're not asking for perfection here, right? We let them know you're trained, but then you're going to want to ask for that assistance. And they're going to help walk you through it, but only if they are emergency medical dispatch trained. So at this point, the dispatcher will then read the statements from the cards that provide step-by-step instructions, again, only if they are trained in emergency medical dispatch. If they're not, they will not provide the steps for CPR. And that is why it is of the utmost importance. It is imperative to do those monthly medical emergency drills, such as practicing CPR with the staff of your agency. And then, of course, if you have another person with you, dispatch might ask questions while the other person takes over compressions. If you are lucky enough potentially to have two staff that are there, or circumstances, just happen right, we do want staff to know to immediately go into CPR. This might be before the call is even made. And so you want to drive that home, that the sooner CPR is being implemented, then the sooner the individual those life-saving techniques might actually end in a good result. Next slide, please. All right, scenario 3. We've talked about this, right? This is an example if the 911 operator is not trained in emergency medical dispatch. Dispatcher, where's your emergency? You provide the location. Dispatcher, what is going on at this location? Provider, the individual is unresponsive. The individual is not breathing. Dispatcher, well, have you started CPR? Provider, no. Dispatcher, okay, EMS is on the way. And then the call is disconnected. Please recognize this scenario is very possible. And this is why it is so imperative to practice emergency medical drills, because although that dispatcher hung up, it is still the responsibility of that staff to implement that training and implement that CPR if it is needed in that situation. Next slide, please. Okay, so just some frequently asked questions really quickly. How do I know if my service is in a jurisdiction that is trained in emergency medical dispatch? You can contact the local non-emergency number for your emergency communication center, and you can request that information. Why do I have to know my address? Don't they know where I am when I call via my phone? This is a great myth. We've all seen it on TV. No, 911 centers operate by receiving a call via cell phone and the cell phone hitting its closest tower. The tower then communicates to the 911 center and notifies them of the incoming call. However, this tower could be located on the line or in 2 jurisdictions and send you to the wrong center, or the signal produced nothing further than the tower location and not your physical location. Technology is the basis of a 911 center, but we have to ensure that we are able to provide information when technology fails. What if I'm unsure if I can make it to the door to unlock it? Is there a way to communicate a spare key for access? Yes, love this. Contact your local communication center, request the information. You can add it to your address information, the key location, I said that oddly. Contact your local communication center, request the information, be added to your address information. They won't air this over the radio, but the responding medical personnel or law enforcement, whomever, will know the location of the key. And of course, it can be very beneficial. Why is the dispatcher asking me so many questions? The dispatcher has a responsibility to you, the individual, the first responders. They're really trying to keep everyone safe while helping as quickly as possible. And so gathering information allows for them to bring all the equipment they need, administer all of the help that they need. And then remember, the dispatcher is not the person coming to the scene, but they are information gathering for those that are. So we have to also be patient with them. Next slide. Okay, and then just a few more questions. What other information can be added to my address for first responders? If your individual utilizes Project Lifesaver, your home has an AED, potential hazards accessing the home, dogs, animals, etc., any other pertinent information that's going to help aid in the safety of the individuals, that information can be added. Why are the emergency medical drills important? Throughout the course of your work, there will come a time where you'll have to call 911. It is stressful, especially when it's your first time being in an emergency. And so the best way to succeed is to practice on a regular basis. Practice is accomplished through those regular medical emergency drills. What if I know how to do CPR, but I forget due to the situation being stressful? We see this a lot. Then you say it. The 911 dispatcher is there to help you. If, again, they have been trained, they will help. It's imperative you follow their instructions. They stay on the phone with you, support you. So please don't hesitate to ask. And then remember to debrief with your staff after an emergency drill and especially after an actual emergency. Most important, you are the key to success. Success comes through practice. Be sure to practice calling 911, practice CPR. Next slide.
Okay, thank you, Christina. So this slide here shows a sample draft of an emergency medical drill form. And of course, it's important that providers document all drills. You can see the sample form gives instructions to staff of examples of medical emergencies, some example scenarios, the type of drill, the location of the drill, the type of scenario, a section for assessing the drill, for debriefing the incident, for staff participating in the drill, and any corrective actions needed for future drills, and of course, the signature of the staff completing the form. Next slide. Okay, we're going to wrap it up here. So we encourage you to seek out the full PowerPoint presentation that will be posted on the OIH website in the near future, as it includes a more in-depth review of our Regulation 530, which is the Emergency Preparedness and Response Plan. We reviewed our Regulation 700, we reviewed some 911 scenarios, and covered some frequently asked questions. Remember, not all 911 centers are training emergency medical dispatch. And also remember, it's important for your policies and procedures to clearly outline your employee responsibilities during a medical emergency. It is vitally important to incorporate those medical emergency drills into your policies and procedures and your emergency preparedness drills. We thank you for your time today, and we hope you have found this presentation helpful. Thank you.
Thank you very much, Angelica and Christina. Lots of good information. And for those who joined us later, you can put your questions in the chat. We'll be answering them at the end of the presentation, as well as sharing the slides that were shown to you today. And next we have, instead of Amy Britton, we have a change in our presentation. It will be Katie Morris from DMAS. Katie, good morning.
Hey, Sophia, good morning, and good morning, everybody. Thank you all so much for giving me a little bit of your time this morning. I appreciate it. My name is Katie Morris, and I am the Quality and Service Integrity Manager at DMAS. And I'm just here to a little bit to give some updates and some reminders of where we are with the HCBS settings regulation implementation. So this slide just covers a couple of updates. We thought that you all would be very interested to know that we are about 85% complete with our initial reviews, which is amazing. It has been a long time coming. It has been a long 4 years, but we are making our way to the finish line with this step of the process. Less than 1% of providers were deemed unable to comply or meet the expectations within the regulation. So a huge thank you to everybody on this call who has worked so hard in meeting compliance and maintaining compliance. We are very grateful for all of your hard work. We did make some updates to Chapter 2 of the DD manual. It was posted for public comment for 30 days, of course. And we made some in-depth changes to the HCBS section. Those start at about page 30 of Chapter 2. And of course, all manuals are available on the DMAS MES portal for providers. And we are also actively working together, DMAS and DBHDS, on planning for our ongoing monitoring strategy to ensure that once every provider hits compliance, they're able to maintain compliance, and that we are able to attest that to the good folks at the Centers for Medicare and Medicaid. So we will be providing additional training and information once we have that process ironed out. I don't want anybody to think that something new is going to happen without being informed. We will be doing trainings. We will be putting out information. We just are not We just are not there yet. The other thing that we do have on this slide is an ask for you all. If there is something related to the settings rule that you think would be helpful to have more in-depth training on, please send us your ideas. You could either send them to hcbscomments@dmas.virginia.gov or put them in the chat. But we, are always interested in ongoing topics that would be helpful and useful to you all. So if you have anything in mind, please let us know. Next slide. So here are some reminders of things that we are still continuing to see as we are doing reviews. And so the first one would be, again, provider policies that are not compliant with the HCBS regulation. So the main example of that is some kind of a blanket rule, whether it's no alcohol or no smoking or no visitors or something that's just blatantly in conflict with the final rule. As we're going to get to it with some reminders for the modification section. But the whole purpose of the final rule is to focus on person-centered planning and person-centered principles and practices. So the idea of a blanket rule is really in contrast for that. We want to think about what is needed for the individual. We want to ensure that the HCBS policy is appropriate for the service you are providing. This is mainly for our newer providers, but for our newer providers, occasionally we do see somebody will be having a day support and they take one of the sample policies from the website, which they are intended to be a resource, but they will include a bunch of things around like residential rights and having leases and things like that. So just make sure your policy is applicable to the service you're providing. And the next one is around lease agreements. Please remember that all individuals in a provider-owned or controlled setting are entitled to a lease agreement that contains reasons for evictions and outlines the right to appeal that eviction notice. And new providers have to be compliant before they are able to enroll as a Medicaid provider and begin to get reimbursed for their services. That's done through a self-assessment process. You only need one letter per service. So let's say you are going to open up a group home. And then you come in, you do the assessment, and you open up the group home. If you were going to open up like a second group home, you do not need a new letter. Because this is just a review of policy. The new location is still subject to a review of practice, but the policy review really only happens one time. I did want to remind folks that providers are prohibited from direct billing of individuals for services, regardless of approval or denial of authorizations. This does not include individuals that have been determined to have a patient pay or a copay or something that's been determined. But just in the event that a service is denied for some reason, or there's a reduction in dates, direct billing to the individual receiving services is strictly prohibited. It is a violation of DMAS regulation and policy, as well as the Federal Centers for Medicare and Medicaid regulations and policy. And then lastly, the HCBS reviews are ongoing, and it is possible that a provider will have more than one review for a location. And that can be initiated if there is a complaint or there was some kind of just a random selection, or the provider had a heightened scrutiny status. Next slide. So I wanted to talk for the remainder of my time around modifications. So back in June of this year, the Centers for Medicare and Medicaid, as well as the Administration for Community Living, did come to Virginia and they did a settings review. And one of the main takeaways was that there seems to be a whole lot of confusion from providers and support coordinators and individuals and families around modifications and how a modification works. So, an HCBS modification is not a quote unquote restriction in the same way that providers would think about like the human rights process. And if you have any questions around the human rights process, please direct them to your advocate. Some folks ask me, I can't answer them. I will direct you back to your advocate. Um, so what can be modified are the residential specific rights that could cause health and safety concerns, including access to food at any time, locked doors, or visitors at any time. The fundamental rights of like access to a community, choice of providers and supports and who provides them, those rights cannot be modified. So we are only talking about modifications for the residential specific rights. The next question was just what can't be modified. And again, that's access to the community, privacy, dignity and respect, freedom from coercion and restraint, autonomy and choice of services and supports. And so how does the modification process work? This is the main question that I get. So modifications are team-based decisions that must include participation from the individual, guardian, family, if they have an involved family, providers, support coordinators, and outside professionals as necessary. So if a person had like a doctor or a therapist or something, that temporarily restricts one of the residential specific rights. The team has to come together, discuss the safety concern, discuss less restrictive alternatives that have been tried, outline time periods for review of the modification, and gain consent of the individual. While providers are tasked with the implementation of the modification, the provider has to collaborate with the team prior to implementation. And the HCBS policy of the provider has to reflect their internal process for a modification. And then next slide, please. So this is every area that the modification has to include within the provider policy, which is identifying the specific individualized need, documenting positive interventions and supports that have been used prior to looking at the modification, documenting of less intrusive methods that were tried but did not work, have a clear description of the condition that is directly proportionate to the need, include regular collection and review of data to ensure that the modification is still needed, establish time limits for review, and at those time limits, you do have to review whether the modification could be terminated. You have to have the informed consent of the individual and an assurance that the interventions and supports will do no harm. Next slide. So here are just some reminders about modifications. The HCBS modification process does not replace any required processes from the DBHDS Office of Human Rights. The modification should be documented in the Part 5 of the ISP in the safety restriction section. If that form is completed, it ensures that all elements of the modification process are covered because we designed that that section based off of the final rule. Modifications have to be person-centered and based on health and safety. The HCBS regulation does not allow for modification based on preference of the family support coordinator or provider. And then the last one, and this one I really want to hit home, that modifications are person-centered. So they just reflect the needs of the person in order to keep them healthy and safe. So if a person has a documented history of, eating uncooked food, for example, or putting them in a situation that is not healthy or not safe for them, and a modification is required, that is in no way a poor or bad reflection of the provider. That shows that you are taking the steps to keep the person healthy and safe. I've heard that some providers feel like if they have a modification, it in some way makes them look bad, like, that they had to go through this process. That is not the case. We have to ensure that the process is followed. We want to ensure that individuals are not having modifications for reasons that are not grounded in health and safety. But that is in no way a reflection of the provider. Just make sure that you're following the process, and as soon as it's safe, that the modification is removed. Next slide. Okay, yep, I thought that was it for me. Thank you all so much for your time this morning.
Thank you, Katie. And now we'll have Mackenzie Glasgow from the Office of Licensing. Mackenzie, good morning and welcome.
Good morning. Thanks for having me today. We'll go ahead and go to the next slide. So today, what I am going to be going over with you all is related to the 9th semi-annual adequacy of support summary, as well as providing some reminders related to corrective action plans, on-site reviews, and the issuance of licenses. Next slide. I'm going to first begin by taking a look at the 9th semi-annual adequacy of support summary. This covers January 1st, 2024 through June 30th, 2024. This summarizes the trends related to the adequacy of individualized supports and services provided to individuals with developmental disabilities who are receiving licensed services. Next slide. So a little bit of background, the Office of Licensing is tasked with monitoring providers' compliance with the rules and regulations for licensing providers, which involves monitoring the adequacy of individualized supports delivered by those providers. So at each annual inspection, the licensing specialist reviews a sample of individual records to ensure that individuals being served are receiving services consistent with their assessed needs and their agreed upon service plan. So if a review uncovers that a provider is not meeting an individual's needs, then the appropriate regulation is cited, is required to submit and implement a corrective action plan for each violation cited, which should include a detailed description of the corrective actions to be taken to correct the specific deficiency identified for those individuals' records who were reviewed, that will minimize the possibility that the violation will occur again, and that will correct any systemic deficiencies. Next slide. So I've got a couple of charts in the next few slides. These charts displayed actually tie those 8 domains outlined in the settlement agreement to the specific corresponding regulations. The chart also lists the documents that are reviewed by the Office of Licensing as part of the annual inspection process. This is both for developmental disability private providers of non-case management services, as well as developmental disability providers of case management services. So the first column includes the domain, the domains, which on this chart includes safety and freedom from harm, and physical, mental, and behavioral health and well-being. If you go to the second and third columns, those list the corresponding regulations and the minimum documents that are reviewed for all developmental disability services except for case management. And then the fourth and fifth columns list the corresponding regulations for case management services and those minimum documents that are reviewed. Again, the format's going to be similar on the next few slides, so we'll go to the next slide. So on this one, this is specific to the domains avoiding crises and stability. So as you can see here, there is no corresponding regulation that aligns with stability specific to DD private providers of non-case management services. However, for case management services, that is measured by collecting data specific to Regulation 1245. We will talk a little bit more about how stability is measured for developmental services except for case management a little later in my presentation. Next slide. On this chart here, you can see the domains are choice and self-determination and community inclusion. Next slide. And the last 2 domains that are of the 8 are access to services and provider capacity. Next slide. So in accordance with 5G3 of the settlement agreement, the Commonwealth shall ensure that the licensing process assesses the adequacy of supports and services provided to individuals with developmental disabilities receiving services licensed by DBHDS. The Office of Licensing is required to produce a summary report obtained from the Adequacy of Supports checklist and share the aggregated data with the Case Management Steering Committee and other relevant key performance area work groups, and with you all. We like to share this information. Next slide. So today we will take a look at the AOS data specific to developmental disability private providers of non-case management services. So this slide, it shows an aggregate and detailed report for January 1st, 2024 through June 30th, 2024, which calculates the overall ability of the provider community to meet the individual's support needs for the domains. So by reviewing individual records for compliance with the regulations that are tied to each of these domains, as well as aggregating the data from inspections, DBHDS is better able to assess the adequacy of supports on both an individual and systemic level. So what you're looking at here is a screenshot of the report that is from the Office of Licensing Information System, which is Connect. This pulls information for the regulations tied to those domains for providers of developmental disability services as outlined in that crosswalk that I just shared with you all. For this data, the time period is selected and the diagnosis group as well. So it is important to know that data is pulled separately for DD private providers of non-case management services and DD providers of case management services. The adequacy of supports report will pull compliant, non-compliant systemic ratings from all annual inspections, DSI inspections, human rights inspections, in-office reviews, as well as investigations, re-inspections, and any technical assistance. For all inspections other than the annual unannounced inspection, the regulations that are marked are selected based on information that is reviewed relevant to the inspection purpose. The report selects the regulations regardless of the status of the inspection, so whether it's open or closed, or if there's a corrective action plan, whether it's issued or pending, and it returns all the results. It is important for you to know that if a provider had a regulation reviewed multiple times over a year due to enhanced monitoring or a follow-up inspection for a health and safety cap or an investigation, just to name a few, and the specialist or investigator reviewed some regulations multiple times throughout this monitoring period, all those times that those regulations were reviewed are pulled into this report. Next slide. All right, so during the 9th semi-annual reporting period, we're talking about January 1st through June 30th of this year, developmental disability private providers of non-case management services met the individual support needs 88.29% of the time. So the overall AOS rating actually increased significantly since the 8th semi-annual reporting period, which was at 80.44%. During the 9th semi-annual reporting period, 7 of the 8 domains were above 86%. The only domain below 86% was provider capacity. Next slide. All right, so in this chart, you can see an increase in each of the domains except for provider capacity. However, that did increase from 60.75% to 76.47%, which is almost a 16% increase. So that's good. If you're looking at this chart, you can see the darker blue is the data for the 9th semi-annual reporting period, and the lighter blue is for the 8th semi-annual reporting period. We'll go to the next slide. So remember, there are specific regulations that correspond with the domains. So the specific regulations where developmental disability providers of non-case management services had difficulty meeting compliance are listed in the chart here. So those regulations are actually tied to the following domains. So access to services, choice and self-determination, provider capacity, and safety and freedom from harm. So all those regulations that are listed on this screen here were below 86%. So providers need to ensure that they have processes in place to demonstrate compliance with these specific regulations. If you've been cited for any of these regulations, be be sure that you have implemented your corrective action plan and that you're monitoring your CAPs in accordance with your quality improvement plan. Now let's take a closer look at some of these regulatory requirements. We'll go to the next slide. All right, so these are the regulations below 86%. 645B5, that is actually specific to the screening form, including the disposition of the individual. And this should include their referral to other services, placement on a waiting list, or if they're admitted to the service. So if you were cited for this or not, make sure that you are meeting this requirement. 675D3, this has to do with completing the quarterly reviews of the ISP within the required time frame, meeting to review reasons for lack of progress, and provide the individual an opportunity to make an informed choice on how to proceed. Next slide. Regulation 450. So for this one, please make sure your training policy addresses the frequency of retraining for all areas. These areas are serious incident reporting, medication administration, behavior intervention, emergency preparedness, and infection control to include flu epidemics. If your agency does not administer medications, then your policy should reflect that. So make sure that you are including that if you are not administering medications. All right. Also, all training must be documented by the provider. 665D. This has to do with making sure that your staff have a working knowledge of the ISP, every individual's ISP, as well as knowing their health and safety protocols. So this type of training should also be documented as well. Thank you. 160C, providers have to collect, maintain, and review at least quarterly all serious incidents. Last year in 2023, we had a training called Minimizing Risk, where we shared the individual and monthly risk tracking tools. They are now, or they have been, located on the OL website for your use. But these tools are going to help you track those serious incidents. They will also help you with the piece that requires you to analyze for trends, identify potential systemic issues, indicate remediation, and document any steps taken to mitigate the potential for future incidents. If you're not using that tool, please take a look at it on our website. It is really helpful. If you're not sure where to find it, feel free to reach out to your licensing specialist. Again, that's the monthly and individual risk tracking tool. Those are very helpful for providers. 160D2, remember that level 2 and level 3 serious incidents need to be reported to the department within 24 hours of discovery. We'll move on to the next slide. 160E2A, this has to do with your root cause analysis policy, making sure that there is a threshold number for similar level 2 serious incidents that occur to the same individual or in the same location within a 6-month period. Remember that when you meet a threshold number, as outlined in your policy, you are required to conduct a more detailed root cause analysis. 665A, if an individual requires a safety plan, making sure that that's included in the ISP. This also includes a fall risk plan if they need one. So those regulations that I just went over with you, those are the ones that are below 86%, and we really need you all to take a look to make sure that you are coming into compliance with those if you were cited previously, and that you maintain compliance with those regulations if you were not cited. All right, so stability. I talked about that a little bit previously. As stated, this domain does not directly tie to any regulations for DD providers of non-case management services. So the Division of Crisis Services measures stability as the number of individuals with a developmental disability who were not discharged by the residential services provider around the same general time of a crisis and were either admitted to a CTH or to a psychiatric hospital. So the goal is that 25% or less have had to move after their crisis. Data from the 9th semi-annual report shows that 96.75% of individuals remained with their original residence during the time period of January 1st, 2024 through June 30th of 2024. So providers are doing a really good job of continuing to support these individuals, and we greatly appreciate it. Let's move on to the next one. All right, the DSI late reporting compliance report. This is specific to 160D2 and whether or not providers are reporting those serious incidents within 24 hours of discovery. So this report shows that during the 9th semi-annual reporting period, that private providers of non-case management services who reported level 2 and level 3 serious incidents were compliant 96.13%. So again, this is for those that did report. Back to the other one, we were talking about 160D2. Those were identified during an inspection because they did not report those incidents. So make sure that you are continuing to report level 2 and level 3 serious incidents as you should. All right, this next slide, this just talks about some of the steps the Office of Licensing took to support providers. We did update our sample provider quality improvement plan back in March. We provided DD inspection training at the beginning of the year. We provided memos. We posted PowerPoints. We will be providing training as we move into 2025 as well. So be on the lookout for that. Next slide. I have a few more. I just want to provide some reminders related to corrective action plans. Please make sure that you are submitting your corrective action plan by the due date. It's always listed on the licensing report that you receive. Remember that an immediate corrective action plan is required for any health and safety violations that were issued. If an extension is needed, you have to request that through Connect. Extensions are not given for health and safety violations. Also, be sure to monitor the implementation and effectiveness of your approved corrective action plan as a part of your quality improvement program. And providers that do not submit or implement an adequate corrective action plan may be subject to progressive action, including a reduction of a license status, denial, or revocation of a license. We'll move on to the next slide. On-site reviews and Connect contacts. You all are aware that the Office of Licensing conducts unannounced on-site inspections per the state code, and we have to conduct these inspections in order to renew a license. It's very important that providers maintain normal business hours and ensure that the primary contact for services and their contact information is accurate in Connect. All providers should have a manager or designee available for inspections, and the provider should cooperate fully with all inspections by providing the requested information. Go on to our last slide. All right, so I just want to provide a reminder related to the renewal application. Don't forget, you have to submit that and proof of SCC prior to the expiration of the license. You'll have to sign and submit the renewal using the Connect provider portal. Connect does send a notification 90 days prior to a license expiring, and it is recommended that you all submit that 30 days prior to the license expiring, if not sooner. Also, prior to submitting the renewal, it's really important that you review the addendum to your license to ensure that you don't have any locations or services that need to be closed, because you will have to submit an information modification, and it would be best to do that, if your license is up for renewal, to do it at that time as well. Once your licenses are renewed, we do encourage you, and it is expected that you review your license and your addendum to ensure accuracy. Again, checking for the locations, looking at all the addresses, making sure that the dates are correct, and things like that. So that is all that I have for you all today. I know that was pretty quick, but we have a lot to cover. I do appreciate your time. If you guys have specific questions related to the regulations, please reach out to your licensing specialist. If you need assistance with Connect, please submit a help desk ticket and someone will be in touch with you. Thank you.
Thank you, Mackenzie. And before we have Maureen Kennedy start, if you have questions, please remember to put them in the chat. For those of you who already presented, if you want to take a look at the questions submitted for your presentations and answer some, that would also be helpful. And Maureen, welcome and good morning.
Good morning, all. My name is Maureen Kennedy. I'm the SIS Quality Manager, the Supports Intensity Scale Manager for DBHDS. Thank you. I'm not going to do a SIS presentation today. What I do want to do is invite everybody to refer back to an email that was sent out by the listserv. We are having SIS trainings on a quarterly basis. The next one is on October the 10th at 1 o'clock. The one following that will be on December the 11th at 10 a.m. And that's where you would find information about the SIS assessment itself. And again, the email for that was sent out on October the 30th. So that's where you'd want to sign up and register for information about the SIS itself, for the assessment, what happens during the assessment, responsibilities for the SIS assessment itself. So the slide you're looking at right now, what I'm going to cover today is what's been going on in the world of SIS. A lot of new stuff that we are very, very excited about. And it's all happening on October 1st. We are finally transitioning to SIS-A second edition. If you've been listening at all to some of the goings on, we've been working towards this if you've been in the DBHDS building here at Central Office, we've been working on this for about 3 years. And it's going to happen on October 1st. There is a misprint on one of the coming slides. It says that the last SIS-A assessment would be done in October 24th, I believe. It was actually done yesterday. SIS-A is, it has been renormed to SIS-A second edition. We're going to talk about the new support levels as a result of this. And I can finally say that the RFP that went out earlier this year or last year, I forget when it actually went out, but we have awarded, DBHDS has awarded the SIS vendor contract to a new company. We have decided to go with, through the contract process, have decided to go with a company by the name of Public Consulting Group. The acronym PCG, you will hear that over and over. PCG, they were awarded the entire state. A little bit about PCG. They are an agency that has experience doing SIS-A second edition, which is one of the reasons we decided to go with them. So we are excited and have already started working with them. So starting October 1st, they will have the SIS contract for the entire state of Virginia. Next slide, please. So in the state, starting October 1st, we will have 3 SIS assessments active in the state. We will continue to do SIS-C for individuals who have active tiered services, and those will be for children ages 5 through 15. Again, only for children who have active tiered services. SIS-A will exist as the assessment, as the SIS assessment used and completed for folks prior to yesterday. It will continue to be the assessment used to arrive at the support level and reimbursement tier for individuals. And then starting on or about October 21st, we will see SIS-A second edition completed for individuals in the state. Next slide. These are the 3 SISs side by side. You'll see, and this is simply just the sections of the SIS. So you can see what's similar and what's different. The thing that's different really between SIS-A and SIS-A second edition is they did some renaming of sections. They did some reordering of sections. All 3 SISs contain section 1, which is where we see our exceptional medical and exceptional behavioral sections. Both SISs contain section 2, and you'll see the divergence in SIS-C and both SIS-As, where SIS-C contains school participation in school learning for the kids or for the children. What you'll see that's different between SIS A and SIS A second edition, I've grayed out section 3 for SIS C or for SIS A. SIS A had section 3. SIS A second edition no longer has a section 3. What they've done is pulled that into section 2 because that's now a part of the norm section of the SIS. So going forward, there will only be 2 sections of our SIS assessment. The other thing that will be different in second edition is if you've experienced a SIS in the last year, almost year and a half, if you've noticed, the interviewers have been asking what we've been calling second advanced questions. Those are the new questions that will be included in the medical section and in the behavioral section of the SIS. We have not been rating those questions or including them in the calculation of the level and tier, the support level and the reimbursement tier. They will be obviously included in section 1A and section 1B going forward as we calculate levels and tiers. It will take Virginia roughly 4 to 5 years to fully adopt SIS A second edition, because it's going to take us that long to move everybody to a SIS A second edition. We will be doing the new SISs as people come due for their next SIS, which is why SIS A will continue to be a relevant SIS in the state. Let's go ahead and move to the next slide. On that first slide, it said that there would be an updated support level. For SIS C and SIS A assessments, we will continue to use the existing support level and tier reimbursement as it exists today. We will continue to have the 7 levels and the 4 tier reimbursements. There will be no change. So for the 4 to 5 years that it's going to take us to complete SIS A second editions as people come due, the existing SIS A will continue to be a valid SIS. This is the new support level and tier reimbursement that will be applied for SIS A second edition. You'll see we're moving to a 6 levels of support for SIS A second edition. This came about as a result of our SIS advisory group that started meeting back September of 23. DBHDS and DMAS partnered with the Human Services Research Institute, HSRI, to study the outcome and the impact of bringing SIS second edition to the state. And on the next slide, what you're going to see, for those of you that are interested, there's a slide that illustrates, and don't go there, go back if you would, if you can. When you get to that next slide, though, there's information and you can see how to look at and review all the information and everything that was discussed and talked about over the 1.5 years that brought us to the information that you're looking at in front of you. The advisory group was instrumental in this 6-level support system. And what you see on this 6-level system is instead of level 6 and 7, exceptional medical is identified as support level M for medical. Support level 7 on our current 7-level system is identified as support level B. So we will not have a support level 6 or support level 7 as an outcome for SIS second edition, SIS A second edition. This will, again, only be done for SIS A second edition. Sorry about that. The tiers are unchanged. We will still have the 4-tier system. Reassessments will only be done as a result of significant and sustained change to the individual support needs. We will not be approving reassessment requests because somebody wants a CIS second edition. There is no change there. Go ahead and go to that next slide. You can see here the Virginia Regulatory Town Hall website. If you would like to look at and see the information, look at all the past information from the town halls and the information meetings that was gone through and reviewed, and all of those notes around the meetings that we had with HSRI, providers, families, support coordinators, all those agendas and meetings. If you look at the agendas, it contains the slides, the meeting notes, and of course the meetings. If you tap on the minutes there, it will give you the minutes from each meeting. The important thing to point out is you need to tap on the meetings tab, search obviously for past meetings. In the partial match, just type in CIS-A and you'll get all of those meetings will come up, and all those meetings are posted there. Again, it's going to take about 4 years to get everybody up and running on second edition CISs, but that doesn't mean we're stopping CIS assessments. Remember, CISs are due every 2, 3, or 4 years, depending on the age of the individual, and they're required. CIS assessments are required. So make sure you're scheduling those when PCG reaches out. Sign up for those trainings that are coming up if you haven't already, and those are not the only 2 opportunities. We continue to do those on a quarterly basis. If you're unable to make them, reach out to myself or Ken. If you go to the next slide, please. I am happy to arrange trainings on an as-needed basis. Very happy to do them. I'd rather you have the information than not have it. So any opportunity to talk CIS, always happy to provide that. Sophia, that's all I've got.
Thank you, Maureen. We appreciate that. And next we'll have Deanna Parker with the Office of Community Network Support on Shared Living. Deanna, welcome.
Good morning, everyone. I think it's still morning, at least for the next 30 minutes. So I have a few updates for you on shared living. I do want to apologize in advance. I'm actually suffering from an upper respiratory issue this morning, so I apologize for my voice quality, but I'm just going to power on. So I want to just give you just a little bit of a refresher on this underutilized waiver service for those who may need that. Shared living is available in all 3 of the DD waivers. And essentially what the service does is it pays for the room and board of a roommate, someone who would be living with an individual with DD, and it's covering up to half of the rent for the roommate's portion. That roommate is going to be providing agreed upon fellowship and companionship supports primarily, but also some limited personal support. So we are defining those as 20% ADL and IADL supports. And the roommate and the individual come together and they agree on those supports in the body of a supports agreement document. Okay, so both the individual and the roommate must be 18 or older, and they're choosing to live together. The roommate, there are some restrictions regarding who can be a roommate in shared living. So essentially, anyone who is serving as someone who is legally responsible for an individual, such as a parent, a grandparent, or even someone who is serving in that role in a de facto manner, is not able to be a roommate. However, it can be a sibling, a cousin, a friend. Okay, so shared living is between 2 people, 1 individual and 1 roommate, and it is designed to be flexible, used with or without rental assistance. And I'll expand on that very shortly. Shared living is not a standalone service, so anyone participating in shared living would need to also have at least 1 other waiver service. and the individual must be named as the tenant on the lease, okay? The important thing to remember, these things that are highlighted here about this service that makes it different than other waiver services, is that the relationship between the individual and the roommate are equal. So the roommate is not a paid caregiver. They are not paid staff to the individual. In fact, there can be no employment relationship between the two. The roommate is not responsible for the individual. They're not providing them with habilitative care. They're not responsible for their health or welfare. They are there to help the individual feel safe in their home and to provide the companionship and fellowship supports just as any of us would have or expect with a roommate. Just another pair of extra eyes and ears in the home. The roommate would have ideally their own life outside of the arrangement. They could have a job, they could be working or going to school. Family and friends are going to be back up for this service primarily, and that will be outlined in the shared living supports agreement. In very specific cases, we would allow for additional waiver supports to be accessed or authorized only in the event that this was not available on a case-by-case basis, okay? Now, the provider is the pass-through for the fair market rent reimbursement, and I'll define that in the next slide, which means the provider is responsible for all of the billing and routing the reimbursement to the individual for the benefit of the roommate, okay? And the support coordinator and the provider equally share oversight in this service. Next slide, please. Okay, so I think this is what everybody really wants to know, so I'll go ahead and get to it. So I want to just talk about the changes to this service and highlight them, and then we'll walk through it a bit. So the primary changes are the rent is now based on fair market rent, okay? The federal fair market rent. So that will increase as the fair market rent increases federally. Okay, so that's one change. The rate also now reflects for the provider both an amount for program support and admin support. All the other waiver services do this. Shared living was different. Now we have sort of amended that so that it works similarly to other waiver services. And the other thing that is different is that we have tied this rate as a reference to the sponsored residential service because we believe that the amount of work that is expected by the provider is somewhat coordinated with those expectations. Okay, so I want to jump right into the reimbursement. Okay, so it is up to 50% of the fair market rent. Okay, fair market rent is equal to monthly rent and utilities, okay? And that is for the roommate's portion up to the maximum amount allowable, right? Reimbursement is based on three things. It's based on the actual rent for the unit, whether or not utilities are included in the rent as indicated in the lease, and where the individual and the roommate are geographically located. So if you look at this slide, the maximum for the rest of state, the FMR, is $839. And for Northern Virginia, it is now $1,022.50. Okay. Both of these maximums include a $100 utility allowance, but only if the utilities are not included in the rent. Not included in the rent. Okay. So in addition to the fair market rent, then we start adding on. Okay, so the roommate can get an additional $25 a month to pay for internet. And then added on to that, they can get an additional $299.50 a month for food. Okay, so I did mention in the previous slide that the service is designed to work with rental assistance. There are very strict federal rules about duplicating federal funds. And so when an individual is receiving rental assistance, the PHA program is actually paying for the full rent and utilities for a 2-bedroom already. So shared living would not be able to duplicate those payments. So if anyone is participating in shared living and using rental assistance, they would only be able to claim food and internet. They're still getting the free room and the utilities paid for by the PHA, but what they're accessing through the waiver service is internet and food. Okay, and that equals $324.50 a month. And as with all services, the provider is getting paid for overseeing the service. And you see here the rates for the provider, okay, for rest of state and Northern Virginia. And those are including both the program support and the admin fee for the provider. Okay. Next slide. Okay, so I want to just help you with a few examples to show you how this works in real life. So say there is an individual and a roommate, they are living in the rest of state, renting a 2-bedroom apartment for $1,000 a month. So the roommate's half would be $500 of that 1,000. Utilities are included in the rent, so the max that that individual's roommate would be able to be reimbursed out of that $839 would be $500. Okay, so let's look at another example in Northern Virginia. So say the rent for that 2-bedroom is $1,800 a month. The roommate's half is going to be $900. And in this situation, utilities are not included. So then we would add that $100 utility allowance to the $900, and so we're at $1,000, and that reimbursement would be $1,000. Okay. One more example from Northern Virginia. So say the rent is $2,000. The roommate's portion is then going to be $1,000. Utilities are also not included in this scenario. The max for Nova is going to be $1,022.50. Okay, so that represents that fair market rent for Nova. So at $2,000, that's actually above the fair market rent. So the roommate's still only going to get that maximum allowable. Okay. All right, so then again, you start adding on for the internet and food, so the $25 and the $299.50. And then you add on the provider's program support and admin fee, and that is the total rate that you would submit to DMAS for billing. Now, a question that some of you might be asking is about the calculation. The provider, the support coordinator, or even the service authorization consultant is not responsible for doing this math. We have a calculator that will do all of this work based on the information that is submitted through service authorization. Excuse me, next slide. Okay, so I want to just talk very quickly about the roles of the support coordinator and the provider in this service. So as with all waiver services, it is the support coordinator's job to connect people to the service. Okay, they will help the person find a roommate and a shared living provider. They're going to help them with the paperwork that they need to submit for service authorization. They will do all the things that a support coordinator would need to do with any other service, including helping them with their goals and what they would be needing in terms of other services and supports. And of course, initiating service authorization. They will be working with the provider jointly to make sure that things are going well with the service and helping to facilitate anything that might need to be changed. Next slide. Okay, so the provider's role with this service is a little bit different because there's a fair amount of work that needs to be done to help set up this service, and it would be the provider's responsibility to do this, okay? And that is happening before service authorization. So the rate rework is really looking at the work that that provider is doing and helping to make sure that that is compensated as needed. All right, so that provider is making sure that the roommate is matched well with the individual, that they are meeting all of the regulatory requirements in terms of the relationship, that there is choice between the two of them in terms of their living together. They are completing all of the screening for the background check. They are ensuring that the roommate completes all the training and that paperwork is submitted as required. They're also working with the two to help with drafting and finalizing that support agreement. As with the support coordinator, they are responsible for checking in to make sure that that arrangement is going well, reminding the roommates about what they are supposed to do to make sure that the individual is getting the benefit of the service. And as I mentioned in the previous slide, they are responsible for the funding. So they are the pass-through for the service. So they are submitting the billing. The individual is receiving the portion for the roommate, and this is how it must be done in order to avoid the individual being that being considered income for them. And then between the individual and the roommate, in some sort of person-centered way, they together would decide how that information is used to benefit the household. And next slide. Okay, so that I promised quick, and that was quick. The last thing that I wanted to say is that this service is still available to be part of the Jumpstart program. So there is the email there if that's something that someone would like to consider. If you have specific questions about the service, please feel free to reach out to Juanita Clements, the CRC, who is knowledgeable about the shared living. If you're a provider and this is something that you might be interested in, reach out to me. I'm happy to schedule a either one-on-one or some sort of group training for providers who would be interested in providing this service. And so that completes my updates. I thank you for your time and your attention.
Thank you, Deanna. Brett, you're on. Good afternoon, almost. Good morning. Welcome. And we'll, again, hold our questions till the end. If you can answer questions in the chat, please do so. Brett?
Good afternoon. Thank you. Again, my name is Britt Welch. I serve as the Director of the Office of Community Quality Management. I want to talk to y'all about two things today. One, a new program that we've implemented in my office, and two, about regional quality councils and some opportunities there for you. The new program that we've implemented, we based this off a previous program that we had done called Consultation Technical Assistance, and we geared that specifically towards Regulation 620C2, which had to do with measurable goals and outcomes being in the in your quality improvement plans. We had a great deal of success with that, so much so that we actually ended up now expanding our ECTA offerings, and we have expanded those to the following regulations: 622, 620 A through E, 520 A through F, and Regulation 450. Mackenzie hit on Regulation 450 a little bit earlier this morning. We are also adding, effective for this round of our ECTAs, a data element that comes from the quality service reviews that HSAG did. That specific data element is looking at providers' use of performance data in their quality improvement and risk management efforts. Now, back in July and August, we sent out a couple of different notices through Provider Connect, and then we did direct invitations to providers. We sent those specifically to the thank you. We sent those specifically to the main authorized contacts for providers that had received a Office of Licensing approved corrective action plan, utilizing those MACs, which are your contact persons that you've listed within Connect. We sent that out through our ECTA email address that you see there on the screen. Next slide, please. So who is eligible for ECTA? Any licensed DD provider that has received a citation during their calendar year 24 unannounced licensing review and has an approved corrective action plan from the Office of Licensing for those subject regulations that you see there. Now, CSBs and providers must complete the ECTA readiness assessment. What that readiness assessment does, it's a self-evaluation of where you see yourself at with regards to your quality improvement and risk management efforts. And that helps us then to begin to tailor our ECTA directly to your organization. So again, you must complete that readiness assessment and provide some additional information that your assigned QI specialist will ask, and they'll give you a due date by which we need to have this. So it's real important that you get the readiness assessment done, meet those deadlines. The ECTA cannot begin without that. And I will ask you, please read the readiness assessment instructions in their entirety before you complete it. So what's being offered? Thank you. Individualized consultation and technical assistance that we're tailoring to your organization in the form of one-on-one sessions, and those will be specific to the focus regulations. And now that QSR or PQR data element that I just talked about, I'll tell you a little bit more about that in a minute. These are going to be working sessions with key members of your organization. You determine who you want to be there. We do recommend that you have your QI person, risk management, and whomever impacts change in your organization. And the reason being, in the course of our consultation with you, you may find, gosh, we need to make a change in a policy or what have you. We need to make a change very quickly. So you want to have that decision maker there that can make those decisions. We're going to be focusing on quality improvement, risk management tools and concepts that align with those focus regulations. And please understand that our ECTA is time bound. There are a lot of providers that we have found. I think we're at last count now, we're going to be up around 400 providers that could be eligible for ECTA. And we want to try to work with as many of those providers as we can. So to help us out, we've estimated the amount of time that we'll be spending on each regulation. And it's critical that providers interested in receiving the ECTA, you really need to make that commitment to actively participate in each scheduled session that we have with you. Where is it offered? We're doing a combination of, you can go ahead and click if you would, a combination of in-person as well as virtual meetings. Some notes for you. The ECTA team, we do not represent the Office of Licensing. We do not issue citations, and we do not make judgments on compliance. ECTA will be stopped to allow the team to work with other providers. Again, I talked about how many there are, all of y'all, in relation to the number of staff that I have. But we will have to stop ECTA under these following circumstances. If there's 3 ECTA sessions that are canceled by the provider, if deadlines for materials to be sent to QI specialists are missed, and if there's no response to 3 consecutive follow-up attempts by the specialist. Now, that doesn't mean you'll never be able to get ECTA. You just go into the next round. So we're not taking the opportunity away from you. We just have to continue to move through each provider that we have in the queue to work with. So it's a kind of a time management and a structure for us, in other words. Now, participation in ECTA is not mandatory. There is no guarantee that if you go through ECTA with us, that you will be found compliant with the focus regulations at your next licensing review. However, based on our experience, we have found that going through ECTA can be very helpful to organizations that are wanting to make improvements within their quality management and risk management efforts. Now, at the completion of ECTA, we'll also send you a link for an ECTA experience survey. And we ask that you please complete this because it's so helpful to us to get your feedback on what that experience was like. In other words, we need to know what are the things we're doing well as a team and in our efforts, and where do we need to make improvements in that? And that survey helps us do that. Now, I did want to talk to you about that provider quality review element. So as you know, with the quality service reviews, they get broken down into person-centered reviews and provider quality reviews. And the specific data element that we've been asked to work with providers on that received and in HSAG terms, your report will read QIP indicated. So that means, I guess in HSAG terms, it's kind of like would be a cap in the licensing terms. It's just they use a different terminology. So that specific data element reads, does the provider collect and track performance data, including serious incidents and other risk information? To be eligible for the ECTA on this data element, you must have received a QIP indicated comment on that question as shown in your PQR report from round 6. The QIP must have been approved by HSAG. HSAG has also provided us with a report that shows all providers that were not found or that were found deficient on this particular indicator or data element. The report provides us with the primary contact for your QSR review, along with contact information. We don't have addresses on there, but we've got email and we've got phone numbers. My office, one of my specialists will reach out directly to you with an invitation. Matter of fact, we're going to send those invitations out to you this afternoon. You can also contact us at our ECTA email address. We have crosswalked that report with the licensing report that we have out of Connect. And if your company shows up in both reports, what we're going to do is just fold those two together. So in other words, we would offer ECTA on their focus regulations and licensing along with this data element from your HSAG review. You can go on to the next slide. So this past Monday, we made our third announcement for ECTA, 620, 520, 450 licensing regulations, and that PQR data element. Does it provide to collect and track performance data, et cetera. Today, we sent that out through Constant Contact. Thank you. And then today we'll be sending direct invitations to you. I hope to be doing that shortly after this meeting. Those will go to your MACs as well as the primary contact that you have, that we have for you in the HSAG report that we have. Now, our expanded ECTA team, it consists of 12 individuals. We've divided the state into 2 territories. In the Western Territory, our supervisor there is Kara Clemens. She's the QIS supervisor. On her team, she has Leanna Craig and Jordan Hyde are the QI specialists in the Southwest region. David Cruz, Micah Davis, and McKinley Harris are the specialists in the Western region. In our Eastern Territory, Tina Harris is the QIS supervisor. On her team, Lisette Bennett and Lauren Gibson are the specialists in the coastal region. Sophia Dunn and Irvin Good are the specialists in the central region. And Andrew Williams, who just recently joined us, as a matter of fact, is our QIS in the Nova region. I will tell you that we have a very diverse team of QI and risk management professionals. We will be doing crossover from one region and territory to the other as needed to meet the demand that we have. And I will tell you also, this team is very, very excited to be working with private providers as well as our CSPs. Next, I wanted to talk to you a little bit about regional quality councils. Next slide, please. The RQCs, as we call them, regional quality councils, they're actually an outgrowth of the settlement agreement. And with that settlement agreement, if you would click, please, the RQCs are charged to identify and address risks of harm, ensure the sufficiency, accessibility, and quality of services, and review and evaluate state and other available regional data as they are available, to look at performance measure indicators and monitoring efforts to identify any trends that we're seeing regionally in the data, and then make responsive actions for improvements within the region. Also, annually, we propose, each RQC proposes a quality improvement initiative to the State Quality Improvement Committee.
Brett, before you speak again, one moment, I just wanted to let those participants on our provider roundtable know we're getting close to time. We will continue, so we have another presenter that will be following Brett. So we ask you if you can please allow us maybe 10 minutes. We do appreciate that and apologize for any inconvenience. Go ahead, Brett.
Thank you. You'll see here, this is an indication of the membership that we have on each of our regional quality councils. Now, these are the memberships. We also have alternates for each of these positions that we have here as well. I won't review those individually with you, but you see it's a very diverse group. Next slide, please. Let's talk about some of the quality improvement initiatives that we have up. You can scan these QR codes if you would click a couple of times there, but this will give you an indication of some of the, just how really involved and how impactful the quality improvement initiatives are that are coming out of our regional quality councils. Next slide, please. And if you're old school like me, and you don't work real well with QSR things, you get to have a link here. Those are links to the same things that I showed in the previous slide. Encourage you to take a look at those. We do have some vacancies, and this is where I really wanted to kind of emphasize to you that we've got vacancies in each of our regions here. You'll see that we've got some high priorities in each of the regions, and that typically is with individuals receiving services on the wait list. So if you are working with somebody that you think might enjoy being on the RQC, please reach out to the quality improvement specialist that's shown here. Some other areas that we need to have filled are family members of individuals, employment provider in Region 4, support coordinator and case managers, and again, family members. So please, if you know somebody, if you're interested yourself in serving on it, please let us know. We'd love to have you come on board. And I will tell you, it is a really good way to be able to get some fairly hot off the press data and information that you might not get otherwise. So would encourage you to really look into this and feel free to reach out to us. I think that kind of wraps up my presentation here. I did include a couple other slides for you to review. If you click, please. A couple of other slides of interest. That's up to you to review over those, but it gives you a little bit more information on ECTA as well as the regional quality councils. And I thank you for your time today.
Thank you, Britt. We appreciate your experience. And lastly, we have Nathan Abel for therapeutic behavior consultation. Thank you guys for working with us.
Hey, good morning, everybody. This is Nathan Hobble, Director of Behavioral Services and Projects. I'll jump in, try to keep it quick. So I've talked in previous presentations on two key areas that we're focused on here in our little unit. That's improving the quality of behavioral programs through the waiver, and then also getting people that need therapeutic behavioral consult connected to it as quickly as possible. Currently, 6 out of 8 compliance indicators that we're responsible for are in sustained compliance as part of the settlement agreement reviews, and that just means they've been met 2 times in a row. So let me talk really quickly about the first area here, quality. We continue to use the BSPARI. That's the tool that we created here to measure adherence to the DBHDS and DMAS practice guidelines for behavior support plans. So that tool's got a 0 to 40 weighted point system. We set overall adherence to these practice guidelines with a score of 34 weighted points or more. But we also recognize that an overall adequate plan could come in with a score range of 30 to 33 points. And those are data that I haven't shared previously that I'm going to outline here in a moment. So right now we're under review as part of the 25th study period. And you can actually jump onto the next slide here, and I'll explain these data. So what we've got here is a visual that's just showing percentage of behavioral programs reviewed across reporting periods to particular BSPARI scores. So that vertical axis, that's just showing a percentage 0 to 100%. And then that horizontal axis, those are the reporting periods where batches, I'll say, of BSPARIs were provided in aggregate to the independent reviewer and his team over the past couple of fiscal years. So what you're seeing here is 2 different measures. That dashed line with the open circle, that's the percentage of BSPARIs that we completed that were at 30 points or above. So overall adequate, not quite at our very robust expectations for adherence to the practice guidelines. And then below that, you've got a solid line with closed black data points, and that shows the percentage of BSPARIs that we completed, again, across these different reporting periods that were in adherence with the practice guidelines. So they scored at 34 points to 40 points on that tool. So pretty obvious when you look at this, you don't need a trend line. It's outlining what the trend is very clearly. There's a ascending trend for both of these measures. So I just want to say, and I truly mean it, I'm really proud of the work that the clinicians out there have done with delivering this service over the past several years, and the efforts that folks have put forward to align their behavioral programs with the expectations that we've got here at DBHDS and with our sister agency at DMAS. You can go on to the next slide. So the second area that we're super interested in is getting people that need this service connected to it as quickly as possible. And the time frame that we have is within 30 days of the effective date of the ISP. that we're targeting to have at least 86% of people that need this service having a service authorization. So there's a lot of data here to take in, but just quick summary, it's showing data points over time with that particular measure. Again, people that had a service authorization for therapeutic behavioral consult within 30 days of the effective date of their ISP. That's a quick summary. I could go into more detail, but I'm going to be mindful of time here. So again, you're seeing a clear ascending trend over time. Certainly work to be done to get to that 86% metric. I just kind of distill it down. There's a lot of different variables that are in play here that have contributed to an improvement over time. And I'll just quickly say, I think it's a reflection of the work that all the support coordinators out there have done, providers have done, and then there's certainly some efforts with DMAS and DBHDS in concert on this over the past several years to improve this particular metric. Then we can jump onto the next slide. And last but not least, just quick updates and some resources. Talked about this previously. We have a provider search engine for this service. We update it regularly. You can access it via a link. I'll pop it into the chat here in a minute. You can also go directly to our website and get it there. Our website has a lot of information on it. In addition to the search engine, we've got training videos on there that we've conducted or other subject matter experts outside of DBHDS have provided. We've got info on quality assurance on there, other professional resources that hopefully will be helpful to people. And I welcome your feedback on that too, by the way. And I also want to note we've got 5 team members now in the Behavior Network Supports Office. So Courtney, John, and Nick have joined us, and they are all diving in headfirst at this point and helping push these efforts along. So we're really lucky to have them here with us to supplement anything that we've been doing, Brian and I, and then previously Sharon and I over the past couple of years here with therapeutic behavioral consult. And in closing, don't hesitate to reach out to me. I'll put my email address in the chat as well. So I appreciate your feedback and any questions you might have. Thank you.
Thank you, Nathan. I appreciate you getting us on time. Guys in the audience, you've been wonderful. You've been patient with us, and we certainly appreciate that. Be sure to put your questions in the chat. As you can see, we're at the time, so we will not be able to entertain the questions, but there should have been answers placed in the chat from the presenters throughout the other meetings. So if you have questions, please reach out to us. I'll put my email in. We'll be compiling all the questions and answers, having them on our website and getting them out to you. If there's anything that we did not give you enough information on that you'd like, also let us know that. Thank you very much for your patience and your time.